presenting with chronic diarrhea. So first, the differentials. The diarrhea may be due to malabsorption, usually a process within the pancreas or a disorder in the small bowel, such as in the pancreas, the patient can have chronic pancreatitis or the patient can have cystic fibrosis. In the bowel, the disorders could be celiac disease, tropical sprue, or Crohn's disease, and even in some cases of lymphoma may present with malabsorption. The colonic disorders that are associated with chronic diarrhea are inflammatory bowel disease, carcinoma, ischemia, and rarely macroscopic colitis. There are some infections that may also cause chronic diarrhea, such as entamoeba and giardia. In some patients, IBS or irritable bowel syndrome may present with chronic diarrhea. And some drugs, such as NSAIDs and aminosalicylates, notorious to cause chronic diarrhea. So let's go for the evaluation. And the evaluation will include a basic history and clinical examination, and obviously it's followed by investigations. If the patient gives history of blood in the stool with mucus and crampy lower abdominal pain, that indicates the diarrhea, chronic diarrhea, is colonic in origin. And as colonic diarrhea may be due to neoplasia, may be due to inflammatory bowel disease, we investigate for them, such as fecal calprotectin to identify if there is any inflammation. Ileocolonoscopy with biopsy that will identify both ulcerative colitis, Crohn's disease, and any malignancy. So inflammatory bowel disease and neoplasia will both be covered if we do the ileocolonoscopy with biopsy. Additional investigations may include a CT colonogram in patients where we cannot do a colonoscopy, and in patients suspected of having cancer, if we want to stage the patient, we have to do the MRI pelvis, especially in patients with rectal carcinoma. If the patient gives history of steatorrhea, which is a fatty stool which floats on water and very foul smelling, that's steatorrhea. If the patient gives history of steatorrhea, undigested food mixed with stool, a reduction in weight, decreased weight, and nutritional deficiency, then we will think about malabsorption. And the malabsorptive disorders include the pancreatic disease. So we have to investigate the pancreas overall. So pancreatic function tests include the fecal elastase and pancreolaureal test. Additionally, to see evidence of chronic pancreatitis, we may also do the ultrasonography and CT scan, and in some cases, MRCP will be required. To diagnose the small bowel disorders such as celiac disease and tropical sprue, we have to do a small bowel biopsy. And for diagnosis of the small bowel Crohn's disease, barium follow-through and small bowel MRI will be very valuable. If the patient gives history of pain which improves after defecation and diarrhea alternating with constipation, change in the appearance and form of the stool, those suggest IBS or irritable bowel syndrome. Along with those investigations, we may also do the other investigations such as stool RE, stool for ova, cyst of the parasites, and stool CS to identify any underlying infection. And obviously, we have to do general investigation to get some general clues and also to assess the patient's overall situation, overall condition, general assessment. We have to do the CBC with yes, sir. We might find anemia, which may be microcytic or macrocytic, depending on which deficiency is more severe, iron or folate or B12 deficiency. We might have to do an iron profile depending on the CBC, yes, sir, and the PBF report. And the patient often has iron deficiency, especially in malabsorptive diarrhea. Albumin is usually low. There will be low level of B12 and folate in patients with malabsorptive diarrhea. Calcium might be low and liver function test might be deranged. Renal function test, including the electrolytes, is important because the patients often, with chronic diarrhea, the patient often have electrolyte imbalance, and RBS may be done in patients.